Good evening and welcome. Welcome to tonight's webinar, What's Your Story? Using Your Voice to Address Disparities in Endometriosis Care. I'm Tanya Hill, Group Account Director for Black Health Matters, the nation's largest health promotion and chronic disease management organization created for Black patients and caregivers. Tonight's webinar is supported by an educational grant from Myovent, Sciences, and Pfizer, and brought to you in partnership with the Academy for Continued Healthcare Learning, whose mission is to design, develop, and implement quality educational activities that have a positive influence on the way healthcare is practiced and ultimately improve the quality of care provided to patients. But just a few housekeeping notes before we get started. At the bottom of your screens, there are 6 engagement tools. As they appear from left to right, they are the media player, share your thoughts, the slides that we'll be presenting tonight, resources, the speaker's bio, and a help button if you need assistance in navigating on the platform. Now, at this time, I'd like to introduce Dr. Linda D. Bradley. Dr. Bradley is the professor of obstetrics, gynecology, and reproductive biology at the Cleveland Clinic in Cleveland, Ohio. Her stellar professional bio is available to you on the speakers tab. However, I'd like to just take a minute to just share with you why we chose Dr. Bradley for tonight's event. Dr. Bradley understands that too many women have been embarrassed to discuss their menstrual and reproductive issues with their doctors. She believes it's her role as a physician to try to fix those things that are correctable and improve what she calls QOL, the quality of life. Dr. Bradley is the physician that listens and sincerely wants to know your story. She's always ready to learn what you want her to know about you, your hopes, your fears, your challenges, and hopefully those metrics can be discussed during her patient discussions. Well, tonight, here's your opportunity to share your story. And with that said, I present to you Dr. Linda D. Bradley.
Thank you very much for such a warm welcome. And indeed, it is a joy and an honor for me to be here tonight because the word doctor in Latin means teacher. And we're going to listen to each other, talk to each other, understand each other's stories. I want to know your story and share with you what we as physicians know about your story and how we can work together in partnership in a patient-centric manner to bring around understanding, treatment, and improvement in the quality of your care. So what is your story? We're going to talk together in the next 20 minutes or so about endometriosis. It is a common disease state. It's not cancer. It's chronic, it's systematic or systemic, but it's often treatable when we know the symptoms. What are those symptoms? It's women who will have cyclical pelvic pain, meaning pain that comes and goes. It's a condition that's often worse near the menstrual cycle where pain and discomfort become more problematic. How does it happen? That's the million-dollar question. We don't have the answer. And there's a theory that the lining of the uterus, that's called the endometrium, gets to go inside of the peritoneal cavity, inside the abdominal wall, and can lead to implants inside that can lead to pain and discomfort. Sometimes so much of the implants or old blood can build up on the inside that when a doctor looks inside, it can look like Hershey's chocolate syrup, can look like firm nodules or bumps on different parts of the organs in the pelvis. And sometimes we can see these nodules by imaging and by clinical physical exam. It's a common condition. Often it's a condition that we can miss because patient stories may be over many years and even over decades before the patient herself believes that there's a problem that warrants a visit to the doctor. How many women? 10% of women of reproductive age, 190 million women of reproductive age, and even young girls will have this condition globally. This is not just a U.S. disease. 11.1% of non-Hispanic white women have endometriosis, 5.8% of non-Hispanic Black women, 2.7% of Hispanic women, and then when we look at a combined racial and ethnic groups, about 6.4%. So while the percentage is different a little bit, I call this an equal opportunity disease. It's not just for one group of women. So lots of women. And the sad thing about learning about endometriosis is sometimes it takes time to put the puzzle together, to have a physician, a healthcare provider, your nurse practitioner to really hear your story. And it can take sometimes up to 7 to 10 years or a decade or more to even get the diagnosis. 80% of women with pelvic pain, meaning that it hurts in your pelvis, can have endometriosis. But don't forget, it can be due to other things. But again, a lot of times to endometriosis. Women that want to have babies and are having trouble getting pregnant, half of those women may have endometriosis. And again, it takes a lot of visits. Nurses, or you see your nurse practitioner, then you may move to a physician, to a different specialist. A lot of money is spent both for office visits, for testing, for medications that may be tried, and even for missing work. And overall, the quality of one's life can also be compromised. So lots of money, $20 billion per year. What's important? What's important is that we talk to each other. You know, this is 2023, and we should be opening Pandora's box to what's going on. There should be no secrets between you and your healthcare provider. Candid conversations, examples of what your pain is like, examples of what the disability you may have. You'll hear a narrative later that I think is really sobering, and that candid conversation that Tiara has, you may say to yourself, you know, I'm having some of those symptoms. And it is important, like many diseases, if we can spot something early, put our finger on it, make a diagnosis, give it a name, we can begin to end the unnecessary disability and loss of quality of life with less pain and suffering. We'll see some images in a moment, a sketch, but the scar tissue that develops, these nodules that are in the pelvic cavity, when you detect something earlier, it's less likely to then have problems with these nodules on your bowels, on your bladder, on the ovaries, on other pelvic organs. And we want to look at the disease state, make a diagnosis, and then treat that problem and not treat 10 other things that it may not be. It's important to know that all doctors are not alike, including gynecologists. And it's important that you begin to do self-advocacy and self-care and learn about physicians in your area where you may see them. You may have a virtual visit. And if it's time for surgery, meaning failed medical therapy, it is important to know that all surgeons are not alike. We really want our patients who likely have endometriosis to be treated by a fellowship trained. That means additional 2 to 3 years after a residency and internship, who have learned extra surgical procedures and techniques in minimally invasive surgery. So if it's possible, that's the kind of physician you want, or someone that's very seasoned, that has been out for a long time doing lots of surgery. Because when you have early diagnosis, we can improve the quality of your life. You feel better, you do better, you are better. And you also, if you're interested in being a parent or a mother in the future, that your fertility outcome may be different. So what are symptoms? again, you don't have to have every symptom on here. Some patients only have a few. One would be pain. It can be cyclical, meaning you know when your period is, and right around the time of your menstrual cycle, and even sometimes at ovulation, the middle of the cycle, there's a lot of pain. Patients, I'll ask them, well, where is your pain? Some will say it's in their back, pain that radiates down their legs. They have very much discomfort with intercourse, sometimes even wanting to avoid having sex. So cyclical pelvic pain that they can almost time on a monthly basis when it's going to occur. Some patients have upper GI symptoms like nausea. Some patients have difficulty, as we mentioned, getting pregnant. The word painful period is also called dysmenorrhea, and that we just talked about. Sometimes endometriosis can, in fact, affect the bladder. Some patients have painful urination. It's not a bladder infection or a UTI. Some patients may see blood in their urine as they void because these nodules invade into the bladder, leading to the blood-like discharge with urination. With poor quality of life, depression, anxiety, some patients have severe sleep issues, and we know today that sleep hygiene is extremely important. Headaches, constipation, sometimes the bowels are affected, and even alternatively diarrhea if there's GI endometriosis or gastrointestinal. So again, what are the issues with delayed diagnosis and treatment? You can get worse. You have poor quality of life. You may not be able to get pregnant. You're spending lots of money for increased health care and even over-the-counter medications. And again, this QOL, quality of life, we want you to be your full self, working your best, doing your best, not calling off of work, not traveling, not enjoying your hobbies. So those are all what we call quality of life issues. This is just a sketch, a little bit difficult perhaps to see, but basically for endometriosis, like staging for other diseases, we have from stage 1 to stage 4. Stage 1 meaning just minimal disease. The doctor may look inside the abdomen and see small speckles of endometriosis that has different colors from red to white to brown. Moderate endometriosis may sometimes start affecting other organs around the pelvis, including the ovaries or what we call the pelvic sidewalls. It can also begin with stage 3 and 4 affecting the bowel, the bladder, and that's when you may get painful bowel movements, constipations, and also blood in the urine. And so we can make a diagnosis of endometriosis. We'll see sometimes with pelvic examination, sometimes with imaging like ultrasound, or sometimes even MRI. So it's great to be a woman in 2023 compared to 30 years ago when I started with this. A lot of traditional meds, but new meds that are on the horizon and here for us that are FDA approved today. So depending on where you are in your reproductive life cycle, when we're choosing with you what medicines to use, one of the things will be, are you ready to be a mom this year or in 5 years or never? So our choices will run the gamut, often related to your desire for fertility. So I'm just going to go through this sort of list of medications your doctor may talk with you about. There may be reasons that you cannot. For instance, one of the early choices is birth control pills. We love to use that. There are ways that you can take pills continuously. But if you've had a blood clot, if you're over 35 and smoke, if you have breast cancer, you can't use that. I won't go into all the medications specifically, but know at this point there's almost like a blank canvas that your physician has. He or she can listen to your story, understand these different modalities that I'm going to mention, and then work with you to make it patient-centric in choosing a regimen that's likely to work and very safe for you. We almost always use non-steroidals. That can be ibuprofen, over-the-counter medications like Motrin, Advil, Aleve, Naproxen. Those are NSAIDs. They work in partnership with other medications. There's a chemical in the body called prostaglandins that is released and can cause pain. Non-steroidals are good unless you have ulcers or other reasons that you can't take it. Then we sometimes use progestins, and there are different types, different names of the medication. So you see here oral norethindrone, we see majoxyprogesterone. Sometimes we use an injection called Depo-Provera. There's also another injection that's given that's called a GnRH agonist. It's been around a long time, and what it does is to fool your body into thinking that it's in menopause. We know that endometriosis goes away once your periods stop, which is between ages 50 and 58. So doctors and scientists over time have developed an injectable medicine that's given monthly. It's been very traditional, different names that you see here. But the exciting things in the last year or two have been oral medications, pills that you can take on a daily basis for up to a couple of years that are, they're called GnRH receptor antagonists. They work quickly, and we give them with add-back therapy, which means a low dose of a hormone that would be about like a hormone replacement medication. We'll talk a little bit about that, but this is a new and exciting area for physicians in terms of prescriptions. And because these medicines came out in 2020 and 2021 because of COVID, there wasn't a lot of time for patients to come to doctor's office to know what's there, and for doctors to get educated on this because we were all very secluded. But we're now up and about, and people meaning the physicians, really know a lot about that. We want to save surgery for last. And so I put in here laparoscopy, which is that keyhole surgery that allows a doctor to look inside and either clean up the endometriosis, excise the endometriosis, and make a diagnosis. We do that laparoscopy more often when all of these therapies that we just talked about fail or don't work. And then we really highlight that as minimally invasive and less of the traditional, what we call open surgery, like doctors used to do. And rarely should a woman in 2023 and beyond require removal of her female organs, meaning uterus and or ovaries. So again, we want you getting second opinions. We want those kind of big open surgeries or hysterectomies to be a really last option. We are into self-care, physical exercise, acupuncture, yoga, pelvic floor therapy, certain types of diets that are anti-inflammatory, putting heat on the abdomen. There are studies that look at cannabis, CBD oils that people take, yoga, mindfulness, prayer, stretch activities, and being positive. So all these things for self-care are helpful in conjunction with working with your physician. It's a multimodality. So what I like to share with you is a great story, a true story that I think resonated for me. And I'd like you to hear it from Tiara and sort of start thinking about, do you have any of these symptoms? Could you guys have been twins in terms of your symptoms? And listen to how she narrates her story and how she was able to later articulate her symptoms with her physician in order to get the expert care that she got. So let's hear Tiara's endometriosis story.
My name is Tiara Jones. I've experienced heavy bleeding, abdominal cramps, and cysts since the age of 15. I was diagnosed with endometriosis in 2005. My intense abdominal cramps would cause me to be absent from work and school. I would be in so much pain that I couldn't move. I would lay there in a fetal position. Sometimes when I was able, I would kind of rock myself back and forth. Other times I would lay completely still and just let the pain go within my body. When I was able to get out and be a part of social commitments, going to the movies or going out with family and friends, I would ask family members or friends to walk behind me to ensure that I wasn't bleeding through my clothes. So often during that time of the month, I would try to wear dark clothing to avoid the embarrassment of possibly having breakthrough bleeding. I felt lonely a lot of the time. I felt embarrassed. I felt like a prisoner in my own body. I felt like I was isolated from every other person. I often compared myself to other women, and I felt like I was by myself. I felt isolated. Talking about my symptoms to other people was embarrassing. Talking about my symptoms to my doctor was embarrassing. It took 6 years to finally receive a diagnosis by my OB/GYN. This is after numerous visits to the ER and urgent care. Endometriosis affected my work in school. I lost numerous jobs due to the fact that I could not be there. I couldn't maintain my attendance and be there when they needed me to be. With school, I ended up dropping out of school because my grades started to fail due to my absence. I had friends who were compassionate and they cared about how I felt, but I also had friends who could not understand it. And because they couldn't understand, they often made me feel like I was doing something wrong or make me feel bad. I felt bad a lot of the time because I could not be the type of friend that I wanted to be. My relationships didn't do well either due to the fact that there were times that I didn't want to go out. There were times that I couldn't go out and really be part of the relationship. I always had this just high anxiety whenever I met someone new, whenever I was around people during that time. I wanted to hurry up and get back home. I just wanted to be in the safety of my house. I felt like if something were to happen, at least I'm at home. I used heating pads, over-the-counter medications such as ibuprofen, Advil, Aleve, Tylenol. Sometimes I would take hot baths and drink herbal tea in an attempt to alleviate some of the pain. Once I was diagnosed with endometriosis, my doctor then prescribed ibuprofen 800, Vicodin, and we tried out 2 different types of birth control pills. The first one was orthotricycline low, and the second was Seasonic at the age of 21. At the age of 26, I was provided even more options. At that time, she told me that I could have a full hysterectomy, or I can have surgery to remove the scar tissue, or I can have an IUD implanted. Needless to say, I was very devastated of the idea of having a full hysterectomy, seeing as though I wanted to bear a child of my own. I wanted to be a mother. So that didn't seem like an option for me. Surgery in itself was scary and still is for me. So having even the surgery to remove scar tissue was not an option either. I was told with the surgery to have a full hysterectomy, I would permanently wouldn't have pain anymore. And then with the removal of the scar tissue, I wouldn't have pain for a while, and it's a possibility that the scar tissue could return. The IUD would stop my period for a couple of years, and of course I would have to keep replacing it. I chose the IUD over the surgeries, and my doctor at that time recommended that I do surgery, but I informed her of my fears, and so we went with IUD. The IUD is very easy. I don't have to remember to take a pill at the same time each day. Sometimes I tend to forget. So the fact that I don't have to remember about anything because it's already there is great. My periods stopped completely after the first year of the implantation of the IUD. And during the first year, the period was very light. I had minimal pain, so I was able to go back to school. I now have a career that I enjoy. I'm able to fulfill social obligations. I'm able to fulfill obligations at work. I have a daughter who is very active, so I feel good to be present in her life. It makes me feel good to be able to go out and do things with her and enjoy spending time with her without being fearful of being doubled over in pain or bleeding through clothes or having anxiety. There are times I still have bad months. There are times where I still have intense pain, but I can honestly say it's far and in between now. I wish on this journey that my doctors early on had listened and had more compassion. I felt a lot of times that I was dismissed. My symptoms weren't taken seriously, and I wish that it were. I wish that I was given this current option of the IUD early on.
Well, Tiara's story was sobering, and I appreciate her honesty, her sharing of her symptoms, the truth telling about her life and its impact, as I've said, on quality of life. Her problem resonated through work, through school, through friendships, through sexuality, through issues with sleep, not feeling confident in herself. So her story is a unique story. And at this point, what I'd like to do is start opening this for some discussion. We do have some questions. And I would say to you, how did her story, her endometriosis story, resonate with you? Do you experience similar things? Are there other things that you noted in your journey? I'd like to hear from you. And we have other questions that have also been coming in that we'll also share. And I'd be happy at this point to answer these questions, Tanya, if you have other questions that have come or are coming through.
Yes, Dr. Bradley, the first question I have is, what can I do to help with sexual pain with my endometriosis?
Well, sexual pain is a real problem for many women. It's important to do a couple of things. Speak with your healthcare provider and your physician. It's important when you go into the office, you need to speak, tell the story. Is it pain with penetration? Is it pain with deep thrusting? Is there pain with certain positions? Is it pain different times of the month, closer to your period or after your period? So try to start keeping a journal of what times of the month, what positions are uncomfortable. And then also it's important for your doctor or healthcare provider to do a speculum exam where they put the speculum in, which is a little instrument to open the vagina to look. Sometimes endometriosis involves the vagina. We can see, remember I said that it's kind of like old blood that accumulates inside the peritoneal cavity. It can have an appearance of like chocolate syrup. It can look blue. So the doctor wants to take a good look around the cervix, a good look at the vagina, and then it's important that your doctor do a pelvic exam. What we're feeling for is to feel for nodules, firmness, to feel if things feel stuck or there's tenderness. There's certain ligaments that hold up the uterus, the uterosacral ligaments. and we try to see if there's pinpoint pain there. To answer the question more fully, a discussion, journaling, and an exam, and then imaging. Because some patients have a lot of endometriosis that can show up on imaging with ultrasound, and or if there's a big concern with use of the MRI. And from that information, your physician can either switch therapeutic approaches, and on some occasions, depending on the staging that might be suspected by imaging, you might require a surgical procedure to, quote, clean up the scar tissue and minimize that scar tissue that's there. So don't be embarrassed about talking about sex. That's what doctors and gynecologists are here for. And so it's an important part of our lives as women. It's an important part of the relationship that we have with our partners. And it's important that you speak and not be afraid to talk with your doctors.
Great. I have another question that's come in is, can you explain more how I might know if some of the newer medications might be good choices for my endometriosis pain?
Well, great question. One of the things that we have learned about this drug is that it works very quickly, and it's oral, meaning you can take the pill once a day. There are some that you take twice a day, and it can be used for up to 2 years. It's very good for some patients have heavy bleeding, but the pain, that cyclical pain with the cycles, because what this does is to stop the menstrual cycles. It kind of fools your body into thinking that you're in menopause. And when you're not bleeding on a monthly basis, it allows your body time to heal. That old blood, it's just like an old bruise on your arm or your leg. We don't do anything with the bruise, but we know it goes away. And what happens on the inside, if every month we're not pushing blood inside, that's one theory, or however the blood gets there, we allow our own immune system to be better fighters and to clean up some of that scar tissue. So I would say it's one of these things, again, you really have to talk with your physician about if you're wanting to have a baby right now, that's not a drug for you. It has add back with estrogen and progestin, just a small amount. So if you've had a blood clot or another estrogen type of tumor, so to speak, you cannot take it. So what I would say is talk with your doctor, say, I've learned about this new GnRH antagonist. Can you tell me more? It's hard on a panel like this to give you specific instructions, but just say, I've heard of something new, doc, am I a candidate for it? I would go with that, but know that it works well. It's very safe. It's very effective. Can be used up to 2 years for what we know now. It may in the future be used longer, and helps a lot of patients significantly with these symptoms.
Great. So another question is, how can I find out if I have endometriosis, and who do I need to see?
So endometriosis, how do you know you have it? It's really by symptoms in general. Again, the cyclical pain, the discomfort, the bad menstrual cramps. Think of everything that you heard in Tiara's story. Not that one person, and she happens to have everything almost, and that does happen. So if you see that you're having these kind of symptoms repetitively on a monthly basis, you first can see any healthcare provider. That could be a nurse practitioner, a midwife, because some patients do see nurses that are well-trained, but they have a protocol where, depending on the severity of the disease, what your pelvic exam is like, to refer you on to a gynecologist. And then ultimately imaging, like I said, the ultrasound or MRI, and sometimes, lastly, we would do a laparoscopy to take a look.
Okay. What happens if it's left untreated?
If you have symptoms, then your symptoms can either, stay the same or get worse. This is not cancer, okay? So it's not like not treating a breast lump that's cancerous. It's basically, again, the quality of your life may worsen. So you just miss out on things. You get more disabled. Again, what we find is that sometimes endometriosis runs in families, and we sometimes, as women, say, oh, my mother had this, or my grandmother or my auntie had this, and we just think it's a woman thing. But when you are missing out on life, like Tiara's story, missing activities, not wanting to be around people, becoming a hermit, she's young, okay? So, I put all this together. Our periods may be a nuisance, but they shouldn't drive us to stay in bed curled up, as she said, lying in a fetal position, keeping heating pads, sitting in a bathtub for hours. That is not normal, even if your mother and grandmother had it. In 2023, as we say, when we know better, we do better. And that quality of life, we should never miss activities because of our period, whether it's pain, bleeding, nausea, achiness. That's just not normal, and you just have to check it out. I know we're not talking about other diagnoses per se, which is about endometriosis, but there are other diseases that mimic endometriosis, like fibroids, like something called adenomyosis, like ovarian cyst. So again, don't make your own diagnosis. That's what I got a chance to go to school for 12 years for, okay, after high school, to do what I do every day and to practice for years and years, as well as other physicians. And so, we have, the ability to work with our patients. And there's a few other questions I see that came in, but I'll pause for a moment, Tanya, to see if there's some other things that have come through, and then maybe I can ask some of these questions also.
Okay. What can you still become pregnant if you have endometriosis?
Yes, you still can become pregnant with endometriosis. What the flip side is, about 60 to 80% of women who can't get pregnant have endometriosis. And what about pregnancy? What do we know? Age matters. So under the age of 35, if you as patients do not use methods of birth control and you have intercourse within 12 months, 85% of women under the age of 35 on their own gets pregnant. So if you're 33, have had unprotected sex for years or a year, have some of Tiara's symptoms or symptoms that have been on our slide, pain, discomfort, the cyclical issues, you should see a physician, because with infertility, 80% of women with symptoms may have endometriosis. And yes, there are lots of women that I've delivered, our friends, my colleagues have delivered, that treat the endometriosis anywhere from medically to surgically, who get pregnant. And so there is hope, but we don't want you to keep having symptoms and then wake up and you're 42 years old, and then it's just harder for everybody to get pregnant. And so again, we encourage women as we age, our fertility declines, and over the age of 35, I do not want to say you can't get pregnant, but it becomes more difficult and challenging with infertility just due to age of the ovaries, with higher rates of miscarriage and things like that. So if you're planning on pregnancy, the news of today is hopefully it's the right time in your life to become a mother, but don't wait till it's too late. And if you have clinical symptoms, see your physician so that you can get a diagnosis. Sometimes you might be on medications that they just kind of keep things smoldering. Your quality of life is good, but the endometriosis is not progressing. So again, it's always talk with your healthcare provider. And if you don't want to be pregnant and have a diagnosis of endometriosis, still use birth control. Because we're not saying, oh, I was told 5 years ago I had endometriosis, it wasn't that bad, and I'm going to have sex, but I'm not going to use birth control. Lo and behold, you become pregnant, even with endometriosis. So we have to sort of look at the whole picture. And if pregnancy is not your goal, one of the treatments or several of those treatments that I talked about can help endometriosis and prevent pregnancy. And Tiara's story sort of talked about her relief with the levonorgestrel intrauterine device, or IUD. Yeah.
Well, here's another question that's come in, is that would pregnancy ever cure endometriosis, that it would go away?
That is a great question, and I wanted to mention that. That's what we used to teach, and it's a little bit true because during pregnancy, what's not happening? You're not having a monthly menstrual cycle. So that is true, but that is not a reason to get pregnant if you're not ready to be a mom. So there is a little bit in those old wives' tales. There's a lot of hormones, progesterone hormones during pregnancy that kind of quiets things down. And many women, after having given childbirth, they may do well. And a certain percentage of patients within a couple of years will be back to clinical symptoms like Tiara's story and the slides explain. But yeah, you can get pregnant, and pregnancy can makes those symptoms better for a while.
All right. Where do you find someone who specializes in treating endometriosis?
So when it comes down to surgery, the way that you can find things are through your local hospitals, asking your physicians what's their experience with treating someone like themselves. And so I think these candid conversations, I love my patients to ask me how many surgeries I've done. Have I seen a case like this? I'm saying for me, but my colleagues. So you'll find doctors now very often discussing their areas of expertise. Or you should have a kind of doctor, and it's for me the same thing. There are surgeries I do not do, but I know who in our hospital system is the expert in that domain. So every doctor does not handle every surgical condition, but should either have the ability to make an appropriate referral and know the colleagues in the area that does it. So I would say look at their credentials, see if they've had additional training. We call it minimally invasive GYN surgery, and or just years of experience in treating conditions like this. How many cases do you do a year, doctor, for endometriosis? You want your physician robustly doing many surgeries, indicated surgeries, of course, for conditions like that. And to make referrals, like I said, if it's not in their domain.
Okay, well, we only have a few minutes left. I don't know if you want to go through any of the additional slides. I think we have about 2 minutes.
Okay. I think I'm just looking here. There are some questions about symptoms to manage. I think one of the important things is managing pain. And we know that right now it's important that we don't get patients addicted to pain medications, okay? And so we don't want patients chewing Demerol and Tylenol with codeine and Percocet. So it's important to manage pain, and that's by managing treatment with all these different modalities. If you are finding yourself in the emergency room getting shots of Demerol, going home with Percocet, that's not good. The ER should not be your place of care. And you would need to get in start with a nurse. The nurse practitioners are well-trained. They should be able to help triage you if you even see a nurse. They're excellent. They're our companions, or a gynecologist. So the symptoms that are important to manage are pain, not like Tiara, missing out of work, being fired, not being able to have a good job record. So those are the quality of life. Successful treatment is to help improve those symptoms that she talked about so vividly. Or successful treatment, if you've not been able to get pregnant, is to be pregnant. So to me, those are the things that we look at. And your physician has to be on the same page as you. Go with questions. Doctors love to talk. We interrupt you guys in 6 seconds to 11 seconds. Put your hands up and say, Doc, just give me 2-3 minutes to tell my story. Go in with the list. Be descriptive. Use your adjectives. It's stabbing pain. It's throbbing pain. It's aching pain. It's painful sex. It's debilitating. and, tell your story. And what I like my patients to do, they probably have heard me speak so much. I go in and I speak and I said, I just want to listen to you. I'm not going to interrupt. I may take a few notes with my pen. Tell me what you want. Quantify your pain. Dr. Bradley, I have bad pain. And then I might say, oh, what do you mean? Scale of 0 to 10. 0 is no pain. 10 is the worst. Where is it 10 to be? If you take Motrin or Advil, if it's a 10 out of 10, what does it go down to? Because that tells me how many Advil are you chewing? You know what I'm saying? Or medications like that. So have the same goals. Know which are the symptoms you want. First treat it. I ask my patient to rank, R-A-N-K, rank order what you want fixed the most. We're going to work on getting everything, but I got to make sure the thing that's bothering you the most is what you tell me, not what I'm guessing from the litany of things that you talk to us about. And so I think it's shared decision making and speaking together with one another, and that's an important thing. And I think we've talked a little bit about this. I know, Tanya, you may have some other questions, but I would say in my sort of summary, speak with your physician, continue to read, self-advocate, eat well, get good sleep hygiene. If you're prescribed medicines, really try it. If you're afraid to take the medicine, call your doctor and let them know for more explanation. Often I will see my patients and say, okay, let's try something for 3 or 4 months. I've written down all their questions like Tiara's story, and they come back and I said, well, how are you doing? I'm the same. And I said, well, how did the medicine work? I didn't take it because I read all this stuff and it frightened me. And that's 4 months wasted of someone's quality of life. So we are here to talk, okay? We have virtual visits now. We have nurses answering phones. And so the better care is a conversation, not to be afraid. Asking your physician when it's appropriate, are new medicines, the GnRH antagonists, for you, because again, we have to triage it to the next step. And the challenge is to continue the conversation, and if needed, to find a new healthcare provider. Second and third opinions are important, and every doctor is not for every patient, okay? And so you will need to find someone where there's conversation, candidness, a sense of compassion, a sense of empathy. Those are things you should walk out with. And when my patients leave from many disease states, I always want to leave them with hope. We will find something to help you with. And I think that's an important message at this time. So I'm going to share some resources here that are on your screen, and I think our moderator may embellish this. Apparently you have these slides for Black Health Matters, the Endometriosis Association, and the Worldwide Endometriosis March. So I'm going to ask Tanya if there's some things you want to embellish here for our participants, and I'll close with this, but just thank you for listening.
Okay, thank you very much, Dr. Bradley. If you can just advance to our next slide. What I'd like to do is, we've run out of time, but there are a few things that I'd just like to share with you before we end this evening. Number one is all of the slides that Dr. Bradley took us through this evening are available to download, as well as there is an upcoming health summit and expo that we are conducting for Black Health Matters on February 11th. There is a registration link in your resources tab as well. And for the first 10 people, if there is still something you would like to share with us from tonight's webinar, please sign up for a 45-minute focus group that we're conducting on February 9th. There is a small incentive of a $25 gift card that we are going to make available. And if you would use the link, and this information is also in the handouts that we're making available to you this evening. So with that, I want to thank you for attending, and good night.
Thank you.